Good morning and good evening, everyone. Before having our main speaker lecture, I'm going to introduce you into hematopoietic stem cell transplantation, the basic, what you need to know. You know types of transplants, your own cells, autologous, allogenic, cells from another person, sibling, unrelated donor, parent or relative, and another sources like peripheral blood or umbilical cord. Here you can see a number of hematopoietic stem cells in the US reported in blue, allogenic, in green, autologous. The hematopoietic progenitor cell sources are three: bone marrow, peripheral blood stem cells, and umbilical cord. In this diagram, the number of matched related donors in the US recipients aged over 18 years by graph. Once again, bone marrow in blue, green for peripheral blood. And here, number of matched unrelated donors, once again, peripheral blood in green and bone marrow in blue. The best allogenic blood or bone marrow donor is a brother or sister. Only 25% of patients are that lucky. There is a 1 in 4 chance that any child will match another child of the same parents. In 1% of cases, a parent may be a donor because of shared HLA types. The compatibility, the major obstacle in the treatment of patients who would benefit from allogenic transplant. Strategies to overcome this problem are the national registries around the world. In this case, the National Marrow Donor Program to find matched unrelated donors have increased the pool of donor options, more than 5 million volunteer donors. Use of umbilical cord blood is another option, and partially matched related donors like haploidentical transplants is another one. Bone marrow, during many years, was the standard source of hematopoietic cell because transplant physicians may select it according to extensive clinical data available, and extensive information was alcohol blood. In this case, physicians might consider the source a good choice, particularly for patients who need an unrelated donor and have an uncommon HLA type or are in urgent need to a transplant. For umbilical cord blood, HLA mismatch is better tolerated because their lymphocytes are naive, even with haploidentical donors, available more quickly than marrow or peripheral blood stem cells for unrelated donors, around 1 month. And if you compare with marrow and peripheral blood stem cells, in some cases, 4 to 6 months. In our case, in Argentina, around 6 months. Reduced incidence and severity of graft-versus-host disease is another possibility. Here you can see number of hematopoietic stem cells by indication in the US, in blue allogenic, in green autologous, and the three main pathologies to allogenic stem cell transplantation are acute myelogenous leukemia, myelodysplastic syndrome, and acute lymphoblastic leukemia. Indications in children for allogenic transplant. Into malignant diseases, acute myeloid leukemia in first remission with a matched sibling, high risk acute lymphoblastic leukemia in complete remission 1, relapsed or refractory AML or ALL, some cases of chronic myelogenous leukemia, juvenile myelomonocytic leukemia, and myelodysplastic syndromes. In this picture, you can see the number of allogenic stem cell transplantation in the US in recipients between 15 to 39 years by graft source, where you can see peripheral blood as a main source for transplant. In this one, relative proportion of allogenic stem cell transplantation donor times in the US, recipient age between 5 years, 2015 to 2020. And you have 4 columns, up to 18 years, between 18 and 39, 40 to 64 and over 65 years. And you can see once again in blue, match-related donors, in orange, match-unrelated donors, in green, Aplo, in light blue, mismatch unrelated donor, and in light green, cord blood. Allotransplant for non-malignant diseases, inherited metabolic disorders, immune disorders, red cell disorders, and marrow failure states. The transplant have 5 steps: conditioning, stem cell infusion, neutropenic phase, engraftment phase, and post-engraftment period. How about the conditioning phase? The conditioning period typically lasts 7 to 10 days. The purpose are by delivery of chemotherapy and or radiation to eliminate malignancy, to provide immunosuppression to prevent rejection of new stem cells and create a space for the new cells. Radiation and chemotherapy agents differ in their ability to achieve these goals. The stem cell processing and infusion. The infusion had 20 minutes to an hour, depending on the volume infused. The stem cells may be processed before infusion if indicated. Some cases need depletion of these cells, and this can be performed to decrease graft-versus-host disease. And pre-medication with acetaminophen and diphenhydramine to prevent reaction is used in every time. How about stem cell processing and infusion? Infused through a central venous line, much like a blood transfusion. Anaphylaxis, volume overload, and rare tissue graft-versus-host disease are the major potential complications involved. Stem cell products that have been cryopreserved contain dimethyl sulfoxide as a preservative and potentially can cause renal failure, other adverse effects, and in addition to the unpleasant smell and taste. The neutropenic phase during this period, between 2 to 4 weeks, the patient essentially has no effective immune system. Healing is poor and the patient is very susceptible to infection. In these cases, supportive care and empiric antibiotic therapy are the mainstays of successful passage through this phase. The engraftment phase, during this period, several weeks, the healing process begins with resolution of mucositis and other lesions acquired. In addition, fever begins to subside and infection often begin to clear. The greatest challenges at this time are management of graft-versus-host disease and prevention of viral infections, especially CMV. The post-engraftment phase, this period lasts for months to years. Hallmarks of this phase include the gradual development of tolerance, weaning of immunosuppression, and management of chronic graft-versus-host disease, and documentation of immune reconstitution. The graft-versus-host disease in these donors cells see, if the donor cells, see the host cells as foreign, the donor cells, lymphocytes, will attack the host. Skin, gut, and liver most likely to be affected. Acute graft-versus-host disease up to 100 days after transplant and chronic over 100 days. What are risk factors for graft-versus-host disease? HLA match or mismatch, lymphocyte engraft, inadequate immunosuppression, and other. Here you can see acute graft-versus-host disease of the skin. In the case, graft-versus-host disease of skin grade 4. And here, chronic extensive graft-versus-host disease. Other problems encountered are hemorrhagic cystitis, veno-occlusive disease of the liver or solid organ syndrome, organ toxicity like lung, heart, or kidney, and in some cases, idiopathic pneumonia syndrome. Here you can see the last slide where I can show you the causes of death after matched deleted donors between 2 years. And you have 4 figures, age under 18 years, and over 18 years. And you can see here the causes of death are the primary disease, relapse, organ failure, in some cases graft resection, graft versus host disease, infections, or others. Well, my thanks to EMT and CMT for sharing educational and statistical information, of course, ATM and the audience. To our main speaker, Dr. Ruswan Shabet, he is consultant apheresis and cellular therapy at the Department of Clinical Hematology of Cellular Therapies at Stanford Medical Center. She's going to introduce us to his topic, called graft cryopreservation does not impact engraftment after allergenic hematopoietic cell transplantation, a single center experience from India. Dear colleague, Dr. Rizwan, it's a pleasure for us to have your lecture today. Thanks.
Thank you so much, sir, for the invite and the kind introduction. Let me just share my slides, and if it is okay, if it is visible to everyone, I would begin. Let me put it on slideshow. Are my slides visible to all of you?
Yes, correct.
Yeah. So I shall begin with a short introduction to our facility, which is one of the largest in Eastern India. And we have completed over 600 transplants in the last 12 years, situated in the city of Calcutta. I have no disclosures to make. And before I get on to this topic, which is basically a single center experience from India, it's our experience where we found that graft cryopreservation does not impact engraftment after allergenic hematopoietic stem cell transplant. I have labeled it half truth to make it more sensational. And to know the other half of the truth, it's important to put everything in the right context. So I may give a brief introduction. I'm grateful to Dr. Claudio for inviting me to this platform and even introducing us to the basics of allergenic bone marrow transplant. So it has relieved me from half the burden of explaining allergenic transplant, where basically, so I would focus on this processing aspect, which is in the red circle, which would comprise of manipulation of the product after collecting from the donor and cryopreserving it until the recipient or the patient is ready for infusion after having received preparative chemotherapy. Now, this cryopreservation, but why do we need to do cryopreservation would be the question on everybody's mind. So ideally, we could keep the cells optimally for 48 hours, maximum at 2 to 4 degrees. But in case if we have to keep the product for longer than that, it is advisable that they are cryopreserved because there would be a degradation or slowly progressive loss of viable hematopoietic progenitor cells, which are marked by markers, antibodies to CD34. So in autologous transplants, where the patient has donated cells for him or herself for later use, we would need to cryopreserve in case the preparative chemotherapy is for more than 5 days or sometimes 6 days. But in allergenic hematopoietic stem cell transplant, it can be done just to enable flexibility in timing of the transplant. So in earlier times, the donor would donate cells and the fresh product could be infused to the recipient because he would have been neutropenic after having got the chemotherapy. But with the advent of the pandemic, the transplant physicians were not very confident and comfortable until they were actually retrieved the hematopoietic stem cells from the donor before starting conditioning chemotherapy, just to make sure that the donor is not infected with the virus and the cells are with them before they start before the patient becomes neutropenic. The other indication for a step cryopreservation would be a cord blood stem cell transplant and even for clinical research. So I need to give a brief intro on cryopreservation. And if I just break the word into two parts, it would, the word cryo comes from the Greek word cryos, which means ultra cold temperatures. And preservation obviously is to preserve its structural and functional integrity. So cryopreservation would technically mean freezing something at ultra low temperatures, ensuring that the cell is viable once it's thawed. However, we have been successful in cryopreserving single cells like hematopoietic stem cells or red cells, or even ovums and oocytes and sperms. We have really not marveled or excelled nature, where the entire creature organism like wood frog, or for that matter, the Arctic squirrel, could actually freeze themselves under hibernation for several weeks at ultra low temperatures and come back alive after the harsh winter is over. As humans, what we have been able to do successfully so far is start trials on trying to preserve solid organs below at sub-zero temperatures, which is quite a challenge given the heterogeneity of the entire organ with several tissues involved. So this challenge is yet to be overcome. And so why is freezing so difficult? Freezing is difficult, or cryopreservation is difficult, because whenever the cell is frozen at temperatures which are as low as -80 or -196 degrees, the cell tends to shrink in size as it loses water if the freezing process is a little slow. And if the freezing process is fast, in that case, the water inside the cell would crystallize, and the intracellular ice crystals will tease the cell membrane, leading to the lysis of the cell and cell death. So slow cooling or fast cooling, both could be detrimental to the cell because there's a change of phase happening from liquid to frozen. In order to make sure that is minimal damage done to the cell while cryopreservation is doing, it is imperative to maintain a controlled rate of freezing, where the effect of the solutes, which are getting concentrated with water moving out, at the same time, the ice crystal formation, their detrimental effect is minimized as much as possible. So it's important to realize that there would be some amount of cell damage during the process. However, we are just trying to find the optimal temperature where the cells could be frozen without either dehydrating them or getting them swollen. In economically or emerging economies in the developing world, the other way of freezing cells would be dumb freezing, which is more cost-effective and widely practiced in resource-constrained settings, where the product is brought down from room temperature to either 4 degrees and then -80, or directly from room temperature to -80 degrees. However, the more preferred way of cooling would be a control rate freezing. How could we minimize the damage while the freezing is taking place? And that could be done by using cryoprotectant, which basically enters the cell and prevents cellular dehydration and ice crystal formation. One of the most popular cryoprotectants of our times is dimethyl sulfoxide, which is popularly called as Dmso, which is used as a concentration of 10%. Now, this reagent is actually being used in the wood industry, and it's quite toxic to human body when used in higher concentrations. So the maximum permissible limit for a human being would be 1 gram per kg per day. And anything exceeding could actually have an adverse reaction on almost all the body systems, right from the CNS, because it permeates the blood-brain barrier. and might lead to seizures. However, the most common side effect that we see is cardiovascular adverse events like bradycardia, hypertension, hypotension. It could be either of them. So cardiovascular adverse effects are more commonly seen. So there is constant research going on to find a cost-effective and easily accessible cryoprotectant that could actually overcome the challenges of DMSO. Ethylene glycol, glycerol, there are other reagents, but none are as good and as widely used as DMSO. And the concentration of DMSO is usually diluted with the help of either plasma light or human albumin, and many centers choose to use donor plasma cells. Now, having given the context of cryopreservation, I would take you back to the traditional practice where hematopoietic stem cells were infused fresh in cases of allergenic hematopoietic cell transplant. But keeping in mind the adverse effects of DMSO and the cell loss, which is actually does take place while cryopreservation is while happening. But with the emergence of the COVID-19 pandemic, fresh infusions took a very severe hit because the availability of a healthy donor at the time of donation was quite a constraint and was something which even the transplant physicians were not sure about. That is why many professional bodies across the globe, be it the American Association of Bone Marrow Transplanters or the Indian Association of Bone Marrow Transplanters, recommended cryopreservation of hematopoietic stem cell even before initiating a conditioning chemotherapy in allergenic transplants. And Western studies reported that there was no significant impact of graft manipulation in patient outcomes. However, there was no available data from the developing world, and that's what stimulated us to look back at our practice. And the aim of our study was to compare neutrophil and platelet engraftments in patients undergoing allergenic hematopoietic cellular therapy with fresh and cryopreserved hematopoietic stem cell products. So what we did was we collected data retrospectively from October 2018 to March 2020, and these were all fresh infusions which happened before the pandemic hit India. So when the pandemic hit India in March 2020 until October 21, when we were trying to capture the data till October 21, these were all cryopreserved hematopoietic infusions. We clearly defined our neutrophil engraftment and platelet engraftment, which were the standard universal definitions of an absolute neutrophil count of more than 500 per deciliter for 3 days, or a platelet engraftment of more than 20,000 per deciliter for at least 7 days, and both of them not requiring any platelet transfusion. And that is when we would label that the patient has engrafted. We did statistical analysis by using Wilcoxon rank sum test, and we took the infusion-related, documented the infusion-related adverse reactions with the help of the National Institute of Cancer scores, which mild reactions, which are very transient, were grade 1. 2, which was infusions were mildly interrupted for a very short time, and the adverse reactions resolved in symptomatic treatment. Grade 3 were a moderate to severe reactions, which could be prolonged and recurrent. And of course, 4 and 5, which should be quite lethal to the patient. Based on this, we, for all our products, they underwent control rate freezing, which we use our control rate freezer. As like all other centers, this is our cooling curve, which is predetermined and programmed. It could vary from center to center. This is what we used, where we started with a very gradual cooling of the product at -1 degree per minute for the first 12 minutes. And after 12 minutes, we brought a very rapid reduction in the temperature by -30 degree per minute. to counter the phase change. Because at this eutectic point, there's a change from liquid to solid with the heat of fusion being released. And the heat of fusion is usually detrimental to the viability of our cells. So to counter that, the acceleration of the cooling was done until the phase change happened. And then it was again a slow cooling until -45 when the phase change is completed. And then it is drastically brought down by -10 degrees per minute until the product reaches -90 in 40 minutes program inside the control rate freezer. Thereafter, the control rate freezing, it is stored in cassettes, which were made of aluminium, and frames kept in the vapor phase of the liquid nitrogen tank, which was maintained at a temperature of -196 degrees. When the cells were required for transplant, they were taken out one by one, thawed inside Ziploc bags in a water bath, which was maintained at 37 degrees. And every samples were sent for quality control, where the viable CD34 count was performed post-thaw, as well as microbiology assessment by culturing the samples for 5 days over the BacT-Alert system. The results that we saw, so we basically had 46 patients in the fresh who received fresh infusions and 50 patients who received cryopreserved products. Now, the median age was quite comparable in both the cohorts, including the sex and the diagnosis. So our diagnosis was quite diverse. It included malignancies like lymphoma and lymphocytic leukemia and myeloid leukemias. At the same time, there was a proportion of beta thalassaemias and benign disorders, which was, as you can see, 10 in each arm. So it was quite representative and equally balanced in both the arms. What we saw is the median neutrophil engraftment in days. When we divide or subdivide the number of the type of transplant in match-related transplants, which are 18 of them, the median engraftment was 16 days and 16.5 days. So it was almost quite same. In haploidentical donors, products from donors, which are like half-match donors, which are 14 of them, the neutrophil engraftment was 16.5 with fresh products, and cryopreserve it was 18 days. So when you see at the median, it looks that it took 2 days extra for the cryopreserved product than the fresh. However, when we use the with Coxon's statistical analysis, the p-value was not significant statistically. The median platelet engraftment in, again, both the categories was almost quite similar, and there was no statistical difference between the two. What was notable was adverse reactions because of DMSO was reported in 11 out of the 50 patients, which was comprising roughly 22%. However, the good thing about this was that the adverse reactions were of mild and moderate category, grade 1 and grade 2. So they were very transient and they resolved on symptomatic treatment. So there was nothing which led to any morbidity in the patient subsequently. The median CD34 cell dose, which both the categories received, was also of the similar range, 3.7 to 4 million cells per kg. The median CD34 recovery, as you see, this is only applicable for cryopreserved products, because for every 100 cells which were preserved, we were trying to see how many cells were alive after thaw, and that was 93.1, which was the median. However, the range was 85 to 104. So if you were surprised at why this would be 104, it could be because of the weight difference, as well as the concentration in each bag would be an estimate and would differ, as well as the coefficients of variability while performing the viable CD34 count. The median viability was around 97%, which and our viability, which was quite good because the lowest that we saw was around 73% and maximum around 99%. Just for the sake of discussion, we tried to compare and see what people have reported from the other parts of the world and what from what Alo had reported from North America. This is Princess Margaret Center, where basically they looked at a data of 958 patients, and they found that there was no difference in either neutrophil engraftment, platelet engraftment, graft failure, or even grade 2 to 4 acute graft versus host disease. But what is interesting is that they also looked at the overall survival, and they found that the overall survival with in patients who received cryopreserved and fresh products, both were same and actually matched, the curves match close to 100 months. And the cumulative incidence of relapse was actually a little higher with cryopreserved products, as we can see. It was in the range of above 20%, whereas below 20% was with fresh. So it looks like there was a difference between the two. However, when they looked at it more deeply in depth, they found that this the most important prognostic factor for incidence of relapse was the disease state or the disease risk at which the patient was transplanted, apart from the conditioning intensity, and not really just the type of graft. However, there were other studies which reported matters of concern, where this study, which was reported in 2021 ASH by Moore, said that cryopreserved peripheral stem cells had delayed platelet engraftment, and it impaired the reconstitution of white blood cells and T cell subsets. In our study as well, what we realized that there was an increased cost to the allergenic stem cell transplant by roughly $1,100 because of cryopreservation, because traditionally they were fresh products that we were using earlier. Even though there was no culture, microbiological culture positive in our cryopreserved products, it has been reported that there could be culture positivity or contamination to close to 1 to 2%, which could be not a great thing. So I can conclude that engraftment kinetics were similar with fresh and cryopreserved hematopoietic stem cells. However, the cryopreserved graft were associated with 7% cell loss, a median loss of 7%, with mild Dmso-related adverse reactions. And there was the incremental cost, as I mentioned earlier. So the take-home message is that graft cryopreservation is a feasible alternative, but which is half the truth. But the other half is, it is important to ensure quality of the graft. And that would involve having skilled manpower, which is able to do graft cryopreservation without losing much cells, and promptly managing DMSO-related adverse reactions during infusion. At the same time, having the infrastructure to do control rate freezing, which comes at a higher cost. So that is the other half of the truth, which goes missing. And it's of great importance for the developing world. The limitations of my study was that there was lack of data because we did not look at overall survival, graft versus host disease, neither did we look at the non-relapse mortality. And our patient numbers were relatively very small. But the way forward is we would like to continue the study and follow up on our patients to collect relevant data for future analysis. I would like to acknowledge our team at Tata Medical Center, which comprises of our guiding light and mentor, Dr. Marman, my clinical colleagues. I take extreme privilege to be at this forum, and thanks to Dr. Claudio and the Asian Association of Transfusion Medicine for inviting me here. I'm indebted to the International Society for Cellular Therapy for accepting my abstract last month and in San Francisco. and the abstract was published in Cytotherapy. Thank you so much for your patient listening. I leave behind images of diversity and color from the city of joy, my city, which is Calcutta. Thank you so much. I'm happy to take questions if there are any.
Thank you so much, our colleague Ridwan Shaved. A wonderful lecture. We are opening the discussion time. At the chat, we have a question for you. How do you manipulate graph in Abo Mismatch allergenic transplants?
That's a nice question. Thank you for your question. So in Abo mismatch something of great concern is the major Abo mismatches, where and in that case, whenever we have a major Abo mismatch, it would always be a peripheral stem cell collection. That is what we ensure first, because with marrow collections in the OT, which is more bloody, and we would like to keep the hematocrit less than 20 ml in the entire product. So if it is less than 20 ml in the product, because at the end of the collection, we would do a hematocrit on the product. And if hematocrit is less, and we would calculate the volume of red cell contamination, if it is less than 20 ml, we would not do anything. We would straight away go for cryopreservation and infusion. In case it is more, then we would like to spin it down and reduce the red cells. Now, to be very honest, when we are using HES, hydroxyethyl starch, but we are very mindful of the fact that we lose a lot of CD34 cells or hematopoietic stem cells while processing. So the target collection would be obviously higher, much higher than we would normally collect if we have to actually manipulate. Yeah, but to be very honest, on all practical basis, we try avoiding manipulation as much as possible and keep the hematocrit low. And apart from that, we would do the titers in the recipient for the anti-A or B, whichever is relevant, depending upon the mismatch that we are talking about, just to see if the titers can be lowered in the recipient. So that also helps in a very big way. We traditionally reduce titers by actually giving donor type plasma, and if the titers are low as less than 512, it's good. We are okay and we are comfortable. So maybe before we start the preparative chemotherapy, for 4 to 5 days before that, they get roughly 500 ml of human plasma from the blood bank, and then we repeat the titers just to check if we are able to break down the titers. So it's a multi-pronged strategy at the collection and at the patient side, both ways. Thank you. I hope I've answered the question.
We could recommend to Tamana Agros to visit our YouTube channel, because we have done a webinar in this specific topic. Dr. Asawari Apat, could you open your microphone? Do you listen to me, Asa?
I'm sorry, is there something which I'm missing out?
Yes, okay, we have another. Please, Asa, could you share your comment or question in the chat? He doesn't open his her microphone. Okay. In our hands, according to the first question, we have at the collection of peripheral blood stem cells, very low hematocrit, no more than 3–4%. In these cases, we have no problem about it. Well, at the chat, Dr. Asawari said, it says host doesn't allow you to open the mic. Okay, could you offer help, dear Ikach, to Dr. Asawari? Dr. Akag, do you listen to me? Well, we have problems with Dr. Akag. I can see.
Hello. Hi,
Could
can
you
you hear
check
me?
right now, Sawari? Yeah,
Yes,
yes, okay.
hey Claudio.
Yes,
It's good to be here, and thank you so much for opening up the mic and unmuting me. So congratulations, Dr. Rizwan, and very nice presentations. I just had a little bit of a comment and maybe a question for you, because I saw in your table where you have mentioned that DMSO was related adverse reactions were around 11 out of 22. So I just, yeah, this one, yes. So I just wanted to ask, did you, because the age group of the patients is not denoted here, that's one. Second, do you think if you would have used a different cryopreservative, such as something from BioLife or Akron or glycerol, anything else, that would have helped? And the third thing was, did you use a change of protocol, such as a wash protocol for before administering the patient? That was my question. Thank you so much.
Thank you for your question. I am happy that you looked into my table in depth. And the age distribution, actually, we looked at, since it was retrospective data, I put the age distribution all together, to be very honest here. If you ask me the breakup, I think it would be difficult. I would be interesting to see. I might just go back and check. But as you rightfully said, changing the protocol, we really didn't think about doing that. To be very honest, I'll tell you why. Because these were all grade 1 reactions, and we are very acutely aware of the fact that using any other reagents, the viability of the cells gets compromised. So honestly, we have not been able to, and we have cross-checked with friends and even other centers in India and abroad, trying to figure out how to go about it. One could be reducing the DMSO concentration, but alternative to DMSO is being not very promising till now, to be very honest. In our experience. And as far as even reducing the concentration of DMSO was not something which we could validate, keeping in mind a good viability. And thirdly, as you said, DMSO washing. Yes, we have a DMSO washing protocol, which we use plasma light, but we use it in case of absolutely severe adverse reactions, where and we thaw one bag at a time. So in case with the first bag itself, the patient throws up a very severe adverse reaction, where we immediately have to halt the infusion and examine the patient with their comorbidities involved. In those kind of, thankfully, we never faced that kind of a scenario. So we were very meticulously trying to note adverse reactions, and they were all mild adverse reactions, which were like transient. We didn't even have to do anything about for most of them, except just go a little slow, and it was absolutely okay. And they were like, sometimes they felt a little itchy, or they were having chest heaviness, which did not actually precipitate in anything. It's just that close monitoring of the patient was required, and all the transplant happened successfully. The alternatives, as you mentioned, they had more of disadvantages, we felt, to be very honest, where we lose a lot of viable CD34 cells, and the chance of contamination during the manipulation or washing. So we really weighed up both ways, and we really don't have a problem with what we are doing. We could possibly try and in a future state validate a process by which we could use, instead of 10%, probably less amount of DMSO. So that is something which we are looking at, and that would be something the way forward. That is how I perceive things. Thank you so much for your question.
Thank you, Rizwan.
A small comment. I'm so sorry. I got cut off due to the network problems. I hope everything is all right. Dr. Asavari, you can unmute yourself.
No,
Everything is
thank
good
you.
to go.
Thank you so much, Dr. Ekaj. Thank you so much. And I think, Dr. Rizwan, just moving forward, me being a consultant to so many global facilities, we are already doing 5% and 8% DMSO, as well as, explore other options. We can take it offline. I'll be very happy to look into it because my alma mater is from India. So very, very happy to, help you through. I spent 1 year fellowship in Tata. So I have very fond memories of that place. And I think at the end of the day, what we're looking for is it's okay to say it's a minor adverse reaction, but at the end of the day, when we have pediatric age group, that's when it starts getting problematic. So it's better to have a validation process or a process in place which will try to improvise on even your hematocrits will be lesser, even your RBCs percentage will be probably it'll go down with the new protocol. So it's like trying to push boundaries. I'll be very happy to share some of the publications with you and then we can take it offline. But thank you so much. I mean, excellent presentation.
Thank you so much. That is so nice of you and forthcoming of you to offer assistance. I would look forward to that. Look forward to your message on the chat box or something. It was so nice of you. Thank you.
Okay, we don't have any questions. At the chat, we don't have more comments. Well, we are very happy to this morning here in Argentina, the evening over there in Asia. Thank you so much to the audience, and of course, thank you so much to my colleague Rizwan Javed for offering the shop. It was a very nice presentation as a very important option to know what happened in this case. In our hands for more than 30 years doing transplants, we only have the expectation to also use the Cryo Preservation in autologous stem cell transplantation. We don't have any experience in the case of Allergenic. But it was a very nice presentation. Thank you so much. Here, as Awari said, that thank you so much for this excellent presentation. Okay. Well, thank you to the audience. Once again, thank you so much, Rizwan. Thank you so much for your participation and comments, dear Asawari. And thank you to our scientific coordinator, Dr. Aikaj, for his permanent support. Thank you and see you next month to another new webinar. Thank you so much.
Thank you.